This paper by Smith and colleagues looks at the use of intracystic glucose and CEA in differentiating potentially malignant pancreatic mucinous cysts from their benign counterparts. It is undoubtable we're finding more and more pancreatic cysts, largely due to the use of increased cross-sectional imaging. The prevalence of pancreatic cysts is quoted to range between 2 and 20%, depending on what studies you read, and of course it's hugely important that we know what these pancreatic cysts are in order to know best how to treat them and also whether patients require ongoing surveillance. Thus, identifying whether a cyst has a malignant potential is of course of huge importance. An important differentiation to make with pancreatic cysts is whether they are mucinous neoplastic pancreatic cysts or non-mucinous neoplastic pancreatic cysts. These latter lesions do not have malignant potential and are generally either pseudocysts or serous cyst adenomas that require no further surveillance. Currently, we're reliant on either histology or the use of CEA to differentiate these lesions, but we know that the sensitivity of CEA ranges between 52 and 78%, and the specificity ranges between 63% and 91% in published studies. Thus, a more accurate method is needed, not only for better patient outcomes, but also to enable us to use our resources more effectively. So this study looks at patients who underwent EUS-FNA, and in this study there were 549 EUS-FNAs performed, with histology sought through the use of tissue, which is obtained either using the microforceps, the Moray forceps, fine needle biopsy, or surgical resection. Of the 549 patients, 93 met their eligibility criteria in that they had histology and sufficient fluid to analyse both CEA and glucose. Now, this study found that using the accepted cutoff for CEA of 192 nanograms per milliliter, this biomarker had the sensitivity of 63% and a specificity of 88%, which gave an overall diagnostic accuracy of 72%. Now, in contrast to this, using a cutoff of less than 25 milligrams per deciliter of glucose, this had a sensitivity of 88% and a specificity of 91%, with an overall diagnostic accuracy of 89%. This is highlighted nicely in this table, which reflects a differentiation in their performance. Interestingly, it found that by trying to combine low glucose with high CEA, the specificity increased, but the sensitivity and overall diagnostic accuracy decreased. This is compared to using glucose alone. So there is no doubt that the development of the through the needle forceps biopsy techniques such as the Moray forceps has improved our diagnostic yield. And perhaps this paper demonstrates that the inclusion of glucose concentration in pancreatic cyst fluid analysis is perhaps a more cost-effective way and perhaps a more effective way to differentiate these lesions that can perhaps work alongside these biopsy techniques. Certainly further studies comparing these two modalities are needed and of course would be of huge value. So read this paper, think about your own practice, and of course watch some of the fantastic material on our website, including the demonstration of EUS-FNA and the use of the Moray forceps.